So we'll begin with Julien. You will talk about the transfusion strategies in massive bleeding. And my question is, you have recipes in Grenoble.
Yes, thank you very much for the invitation. And when you want to prepare a recipe, first of all, you have to choose the good ingredients and to determine the proper amounts of each ingredient. Then you can consider the use of accessories and cooking tools. And as often, the success of the recipe will lie on the secrets and the tips from the chef. So we will start considering first of the ingredients, the use of the red blood cells. We used to reason in terms of targets or thresholds, and we are waiting for the results of the classical biological exams. But today's management must deal on the use of targets, because we will not wait for those results, and we know that waiting for that is time-consuming. In emergent situations, we cannot afford with that time. Moreover, those targets will be dynamic, as they will change with the evolution of the patient, and we'll have to reset our targets at the time of the evolution of that management. All the learned societies recommend to target a level of hemoglobin of 70 to 90 grams per liter, and that level will be increased to 90 to 100 grams per liter in some particular situations, like heart failure patients, patients treated with beta blockers, or in severe traumatic brain injured patients too. When you have then targeted that level of hemoglobin, you will consider the use of other products as the fresh frozen plasma. The administration of fresh frozen plasma must be early done, as in many situations, the patient will evolve with a coagulopathy. It can be the case in traumatic situation, of course, but it can be also observed in postpartum hemorrhage or in perioperative bleeding. In situation of massive bleeding, we will have to target a ratio of fresh frozen plasma to red blood cells between 1 fresh frozen plasma for 1 red blood cell to 1 fresh frozen plasma for 2 red blood cells. That ratio is based on many studies that can be criticized in the methodological point of view, as they are essentially retrospective military studies, but they have been followed with mathematical modelizations, and they have shown reduction of mortality with a ratio over 1 fresh frozen plasma for 2 red blood cells. Nevertheless, we may not confound the massive hemorrhage situation with an isolated biological abnormality that can be observed in perioperative period, and in which the treatment with fresh frozen plasma must be targeted depending of results of different biological standards, samplings, or point-of-care devices that we will be talking about then. Third of all, the platelets will be then administered early too, and in particular in massive bleeding situations or with patients treated with antiplatelet agents, and in situations of intracranial hemorrhage. That early administration will also be facing to the organizational aspects that makes that we will have first available the red blood cells, and the time to have the platelets and fresh frozen plasma available will let us to have a ratio between 1:1 to 1:2, but the target is to finally have a patient receiving at the end a ratio corresponding to 1 platelet unit for 1 fresh frozen plasma and 1 red blood cells. That initial dose will be of 1 unit of apheresis platelets, and this will be the target in massive bleeding, but can be considered again depending on the severity of the patients and the clinical situation. The target in acute hemorrhage will be to obtain at the end a platelet level of more than 50 giga per liter, and that level can be increased to 100 giga per liter in situations of traumatic brain injury or when the bleeding will remain uncontrolled. When you have determined those different ingredients, you can then consider the use of accessories or tools. We have at our disposition available some tools that can be less or more sophisticated. And for example, in my center in Grenoble, we have the chance of using tremolostometry with the ROTEM. But there is other tools that can be used on that situation. What is important to know is that on that emergent situation, what will be the most critical will be to integrate the result of those tools in your algorithms. These tools cannot be used by inexperienced people, and they have to be discussed before the arrival of the patients, the decision that will be made depending on the results of those tools. There's a lack of results in the literature in methodological serious studies showing the impact of those only tools, but what we know is that certainly is the addition of an algorithm added to the tool itself that will be beneficial to the patient. One more not so sophisticated tool, but quite important for the management of the patient, will be the use of protocols. And in massive transfusion situation, the use of predetermined protocols integrating or not those tools will be really important. You have examples of the protocols we use in Grenoble, and it will be decided in cooperation with all the actors that will take the decisions on those situations. Surgeons, interventional radiologists, anesthesiologists and intensivists, of course, but also from doctors from the transfusion centers. What are the tips, finally, if we want to consider, and what will be the take-home messages? Targets are quite more important to consider than thresholds, as they will be dynamic and they will help us to earn money and time on those situations where the patient's management is time-consuming and not waiting from the results from the standard laboratory tests. That will allow an early hemostatic control, and we know that coagulopathy will entertain the bleeding in those patients. That will help the team to go to goal-directed management using or not the results of the tools we can have. And all those tools must be integrated in the organizational aspects that are really the most important points, with predefined massive transfusion protocols, with locally adapted algorithms depending on the means and the resources you have in your center, and considering all the professional and disciplinary different aspects. Thank you very much.
Thank you very much, Julien. We have several questions waiting for the chat. You need to use the chat to send questions. I will ask to our experts. First of all, Julien, you talked about targets, hemoglobin targets. And when you say that it's around 80 grams per liter of your target, does it mean that you need it for oxygen delivery, or does it have an importance in terms of hemostasis?
Yes, it will have both importance for oxygen delivery, of course, and also for the coagulopathy. There is not so much studies in acute bleeding situation, and the comparison of liberal or restrictive strategies of transfusion have been done almost in patients having bleeding, but not so acute than in traumatic massive bleeding, for example. What we know is that the hemoglobin will, of course, help transporting the oxygen, but it will also have a rheological role pushing the different elements between them, the platelets, against the internal wall of the blood vessels.
Okay, Julien, we have a question from the chat. In every slide, you say that you said the term early. Do you mean that we are late in treating this patient with massive bleeding?
So I hope we are not late, but what we know is that the time will be really working against us, and that in severe bleeding, the first priority will to stop that bleeding. So the time will be our first enemy, and all what will help us to earn time will be beneficial for the patient. That's why when the patients arrive in our center, we start a chronometer, and that we define targets to reach, for example, having done the body scanner at 30 minutes or having equipped the patient at 50 minutes. You have to define targets for your whole team, and it's the only way to force you to earn time, so money for your patient.
Okay, you are talking about massive transfusion in a massive bleeding, okay? Do you have different protocols depending on the massive bleeding? I mean, if you are in obstetrics for PPH, for example, or in the trauma center, or in the operating room, for example, in cardiac surgery, when you have a large bleeding after a case. Are there some differences in the protocol?
Yes, there are differences. The protocols are done for two aims. First of all, is that all the team do the same thing, to standardize the practices. And the second aim of the protocols is to earn time when you do not have time in traumatic situation, for example. So the protocols will be different. Overall, we use ROTEM, as I told you, and we integrate the results of that ROTEM on our algorithms. We also integrate the results of standard biological tests, and the targets will not be the same depending on the situations. I take the example of the fibrinogen target in the postpartum hemorrhage will be quite different than it will be in traumatic situation. And finally, those parameters will be dynamic, as we said. And in a set situation like a perioperative situation, we will not consider the result the same way that we will in a young patient arriving with massive bleeding of traumatic origin.
Okay, so I understand you have specific protocols,
yes,
but you're using thromboelastogram devices, viscoelastic devices. We have some public who doesn't have these devices available in their center. Which advice you give to them?
So first, I have to say that the use of that machine must not be done by an only individual. It has to be a teamwork, integrating the biologist on that decision, and it helps to take some decisions, but all is integrated in the algorithm. So people who do not have that devices for any reason can integrate other parameters in their algorithms. They can integrate the results of the biological standard tests. All they have to know is that those results will be obtained later than those from point-of-care devices. So they have to decide the targets and the thresholds they will integrate in the algorithms, taking in account of that data.
Okay, we have a question in the chat. Dr. Fleffel asks, what about the use of central venous oxygen saturation as a tool to guide, I suppose, blood transfusion?
In our practice, we do not use it. It's not a guide. It can be an indicator that you are going in the right direction, but it's a late indicator, and it will not help you making decisions. It can help you comforting your decision that you're going in the right direction, and often it will be the result when the patient will be in the intensive care. But in the initial theater, when the patient arrives in the emergency room, I think it cannot be useful for that. So we do not use it.
Okay, thank you very much, Julien. You didn't talk too much about the factor concentrate. So